So you must recognize these and correct this independently. What is the take-home message? Crouch is best prevented. You can anticipate it from happening right up front in the child that is coming to you. Careful clicalization is a must before intervention. Surgery essentially to reduce the hamstring power, improve the quadricep power, and get the foot and the limb in a better alignment. Thank you very much. Sorry, the videos did not work.
I think we'll take the questions at the end of the session because we're running short of time. So may I invite the next speaker?
Yeah, so for the next talk, I would like to invite Dr. B.D. Athani, and is going to speak on managing upper limb cerebral palsy, the area which we do not usually venture. He is presently Special Director General and Medical Superintendent of the Safdarjung Hospital.
एक मिनट इनेबल करो सर वीडियो चलेगा ना ये करना पड़ेगा
Yes.
Speaking on surgical management of upper extremity in cerebral palsy, somehow in the recent past more and more surgeons have taken interest in management of lower extremity, although the upper extremity has still not drawn the attention or has not been attracted to, has not been very attractive to the orthopedic surgeons. And it is these 30%, 25 to 30% of the hemiplegics type of cerebral palsy who are the candidates for this surgical augmentation of the functions of the upper extremity. And certainly there is no scope for performing any surgical intervention in CP diplegics or severely involved children of the cerebral palsy. And one has to understand at the beginning that when we say cerebral palsy, one has to keep in mind the heterogeneity of the presentation. There is not something you cannot club and make to present it as a series becomes very difficult because of the heterogeneity of the presentation. Every child is a different child. And most of the deformities, either in the lower extremity or upper extremity, occur because of the spasticity, the severity of which varies from patient to patient, child to child. And to start with, it is dynamic, later on it becomes fixed, and then it is fixed with a joint instability, and the same is the case with upper extremity. And let us not forget that when it comes to upper extremity, there is varying degrees of loss of proprioception, stereognosis, as well as two-point discrimination. Therefore, assessment of all the thorough assessment of all these parameters becomes very important. I would slightly differ from my earlier speaker that the gait and motion analysis has a definite relevance in the management of the cerebral palsy children from the point of proper analysis as well as the research, and that is also applied more often to the lower extremity than in the upper extremity. And of late there are many series which have been presented where the gait and motion analysis and dynamic EMG have been used in the upper extremity to assess the grasp and release functions. The principles and objective of surgery is to reduction of spasticity and minimize stretch reflex, correction of muscle imbalance and augmentation of the antagonist, prevention of secondary and bone deformities, improve range of motion, improve aesthetics and hygiene in case of upper extremity, and last but not least, and the most, after doing all this, what is important is we should be in a position to improve the function of the upper extremity. After doing all the surgical correction and straightening the joints and stabilizing the joint, if the function is deteriorated ultimately, then it is not worthwhile. So we have to keep the bottom line, that is the improvement of the functions, or not letting the deterioration of the function should be of prime concern to every orthopedic surgeon. Now, when we say functions, how do you assess the functions? Nobody talks about the scales, but it is very mandatory to use some kind of a scales to know whether what surgical intervention you did, has it benefited the patient in terms of function. You know, the most commonly used functions adopted are one is House functional classification, which has 9 types of functions, 0 to 9. 0 does not use the hand at all, and 8 is the spontaneous and good use of the hand, and in between there is a varying grades of loss. And of late, like akin to the lower extremity GMFSC classification, there is a classification which has emerged as a most useful tool is the manual ability classification system, where it is level 1 is handles the object easily and successfully at most limitation in the case of performing manual tasks. Level 2 handles most object but with somewhat reduced quality or a speed of achievement, may avoid some task or use alternative ways. And level 3 handles objects with difficulty, needs to help prepare and or modify activities, and does the and these are level 4 handles a limited selection of easily manageable object in adapted situations. This is the now most frequently used classification when it comes to upper extremity. And there is one more classification of the function, which is the Melbourne assessment of unilateral upper extremity functions, which has 16 functions to take into account, and which you have to assess pre-operatively and post-operatively, justify ourselves as to what we did has achieved some benefit to the child or not. And let us not forget that IQ plays a very important role in the decision making in cerebral palsy. Confining myself to upper extremity, if the IQ is less than 50 and if the hand placement requires more than 5 seconds, then it is a poor, sensibility is poor, then the goal of surgical intervention is only for improving the hygiene. If IQ is more than 50 and hand placement can be done in more than 5 seconds and sensibility is poor, then improve appearance. And if IQ is more than 50 and if hand placement in a particular position takes less than 5 seconds and if sensibility is good, then it is a worth case for improvement of the functions. Now, pattern of deformities. Shoulder, as all of you know, is adduction and internal rotation. Elbow, flexion, contracture, and forearm is a pronation. Wrist, flexion and ulnar deviation. Hand, thumb in palm deformity, and fingers, swan neck deformity, as well as flexion deformity. This is, in general, are the types, the pattern of deformities that we encounter in case of CP hemiplegics. Now, surgical intervention in case of upper extremity is infrequently done, and there are no controlled studies because of heterogeneity. There is a paucity even in the literature, and there are no uniform tools for assessment of surgical results. Now, contraindications for surgery: athetosis, poor stereognosis, poor two-point discrimination, and inability to position hand in space with eyes closed. Timing of the surgery. This also became a debatable, it was a very debatable issue, but the agreed upon view is that recent analysis of series published in even orthopedic clinics of North America says ideal age for upper extremity surgery is between 4 to 6 years. However, Freeman Miller recommends between 7 to 12 years. But in India, we have been performing the surgery normally between 8 to 15, but we have not set any upper age limit for this. We can take up the patient for surgical procedure even in adulthood, and late adulthood also we do sometimes surgical interventions. Botulinum and splinting, it has been now proved beyond doubt that it has a definite place and definite indication for management of upper extremity spasticity. And if at all, if there is justification of delaying surgery in the early childhood, then one can resort to botulinum toxin and splinting till the child attains the age of at least 8 to 10 years. And having said that, I would say that I will caution that splinting in the daytime when the child is involved in active learning and usage of the hand for acquisition of the skills is prohibited. Child, when he goes to school, must use his hands free of any kinds of external encumbrances. Now, surgical, somehow, those shoulder, we talk about the procedure, but the pattern of deformity that we encounter in India is that shoulder invariably is not very badly involved in majority of the cases, and most of the cases, the problems are distal to the elbow joints. However, for the sake of completion, all these procedures can be done, lengthening and release of infrastructure, spinatus, teres major and pectoralis major. Flexion contractures of the elbow, if it is 40 to less than 40, certainly no surgery is required. Because when you do fraction lengthening of the forearms muscles or the flexor pronator release, that takes care of to some extent the flexion deformity of the elbow too. But if it is between 40 to 90 degrees, biceps lengthening plus brachialis lengthening has to be done as it is shown. This slide is more than 40 degrees. Laceratus fibrosus has to be divided. Then lengthening, actual anatomical lengthening of the biceps and the fractional lengthening of the brachialis is what I do on most of these patients. Now, when it comes to now going distally, pronator deformities, when these again Schwind's and classification is in vogue, that is active supination beyond neutral position, please don't do anything. Active supination to and less than neutral position, maybe we can think of giving botulinum toxin to pronator chordatus, or the Western authors recommend pronator chordatus, but we prefer in India the again pronator teres release. No active supination, only free passive supination, then pronator teres rerouting procedure is done, but the recent articles reveals that there is hardly any difference in the range of supination when you do the rerouting or whether you release the pronator teres release. And when no active supination at all, then release of pronator teres, flexor pronator release can be considered. Now, Jankovic classification, when it comes to wrist and finger deformities, that is the type 1 is the full active finger flexion is possible with less than 5 degrees, 10 degrees, and active extension of the wrist with fingers flexed 2A, and 2B is active extension of the wrist not possible with the fingers flexed, and 3 is extensive deformity of the wrist. This is grade 1, grade 2A with the active extension of the wrist is possible with the fingers flexed, and grade 2B and grade 3. And this is the midline small incision, and we go for, earlier we used to do the flexor pronator release, but that portion has come to be given up now. And when it comes to CP management, you isolate individual tendons and do the minimal fractional lengthening without anatomical forcing the wrist introduction. There is no scope for force. You have to let the tendon slide on its own. You are not even going to do the dorsiflexion on the table, let me tell you. You please don't test dorsiflexion on the table. You have to just do the fractional lengthening and leave it there. That is each flexor carpi radialis, flexor digitorum sublimis, flexor pollicis longus, and profundus, all these are to be divided and forgotten. That's all, nothing more to be done. And then most Green's procedure for augmenting the wrist extension, that is flexor carpi ulnaris to extensor carpi radialis brevis. These are the steps. That is because we transfer it, we don't do lengthening. We take it out from the pisiform bone, reroute it, bring it to the dorsum, and switch it to the extensor carpi radialis brevis, which is the more central. And there are some reports of even advantage of putting it to the extensor carpi, extensor muscles also, EDC, for augmenting the extension of the fingers if that is very deficient. So this is rerouting of the pronators, which I did very recently in the Safdarjung. These are all slides which I am showing from Safdarjung. This is the rerouting of the pronators. And this is, and arthrodesis has a definite place in the management of adult CP patients, because this is one of the wonderful procedure as far as comes to upper extremity surgery. Skeletally mature patients with good voluntary, fairly good voluntary control, if you fuse the joints, advantage is that once for all you will have taken care of stabilize the wrist. Number 2, all the motor power is available for you for transferring to the thumb as well as to the digits. So that is the advantage, and in adult skeletally mature patients, without hesitation, one can resort to the wrist orthodesis, use the available motor power around the wrist for the driving of the fingers, flexors and extensors.
So please conclude, because we're running short of time.
I'll how much time? 1 minute?
It's already overshot.
Okay, fine. I'll just show for this thumb in palm. I finished the thing. Thumb in palm deformity, adductor release, as well as transfer of brachioradialis to the abductor pollicis longus. This is the swan neck deformity, which gets manifest after fractional lengthening of the flexors, and that we corrected by using the FDS stenodesis and post-operative management, splintage and exercises. And this is pre-operative, post-operative, and this is young child with pre-operative, post-operative, pre-operative and post-operative. And this is the better, ultimately we are going to create a better helping hand after doing that. It won't be same as that of the other hand, and dominance can never be switched. And this is the, in short, in a given time of 8 minutes, I could give you an overview of the prevailing trends of the management of upper extremity. Thank you very much.
Thank you, sir, for a very elaborate talk. So next we will invite a debate. Before we invite questions, we will invite a debate on whether to use botulinum toxin and whether not to use botulinum toxin. So first I'll invite Dr. Manoj Padman. So the time of presentation is 5 minutes for you, and for Dr. Alok Sood it's again 5 minutes.
Till he loads his presentation, let me ask, how many of you use botulinum toxin? Can you raise your hands? Okay, there are hardly few. So I think Dr. Padman will make us wiser.
Good afternoon. So I am going to be talking on this debate in favor of using botulinum toxin dynamic spasticity, and I'll try to present the current evidence which is there. So what do we know about botulinum neurotoxin? It's now, the first report was in 1993, so it's almost 2 decades of, since botulinum toxin has been used in the management of spasticity. When injected into the muscle, it inhibits the acetylcholine release at the neuromuscular synapse and thereby reduce spasticity focally. The tone reduction is not permanent, it's not a reversible, but it is a temporary thing. Over a period of time it will wear out. There is a dose-dependent response and most effective when it is used as part of a multidisciplinary rehab program. This is fairly well known. But do we have the evidence for it? Before I go into that, just a diagrammatic thing of where it works. So that is the protein which facilitates the acetylcholine to fuse, the vesicles to fuse into the synaptic membrane and thereby get released. So when Botox is injected, it disrupts the protein and thereby the vesicles are not fused onto the synapse. And just to give a brief overview of what are the other options that you have, it's not just Botox. And as a simple thing, you can divide into whether it's general or that is a systemic effect or a focal, and whether it's reversible and permanent. So Botox clearly is reversible and focal, as opposed to surgery, which is focal but permanent. Now, in terms of the evidence in favor for Botox use, this is what is the current thing. This is a consensus document which looked at it's a multicentric thing, looking at almost 10 close to about 300 patients. And this gives guidelines about the best use of Botox in this thing. This is an updated version of the earlier consensus of 2006. Now, a few key points, I've just kind of distilled through it. It's a very elaborate document. As we all know, it is not to be considered as a treatment in isolation. In fact, Botox facilitates other therapy. Okay, so it has to be part of an integrated multimodal therapy. Additional therapies are must, and the therapy is not a rigid thing. There should be adaptability built into the therapy program, and that is where Botox helps, because it is a reversible process. And what are the adjunct therapies that we talk about? All of us know it, but just to kind of list through it, various forms of functional therapy. They have all their merits and flaws, but just to kind of list them out. So you have systemic pharmacotherapy, you can give oral baclofen and surgery as well. What else did the paper recommend? The clear goals of therapy have to be established so that the carer, that is the parent and the family, are well aware of what are realistic expectations, and for the care provider. It can be focal, that is one site, multifocal, or multi-level approach, multiple muscles can be injected. And the goal is not just spasticity reduction, it has to be linked to a functional relevance. Is it going to improve posture, mobility? Is it going to facilitate care? Is the Botox being given to prevent deformity and pain? So it's not just enough if you say spasticity reduction is the goal. Third guideline in terms of dosages, there are different preparations available, the commonest being Botox and Dysport. They are not interchangeable because the units are different. So it has to be carefully calculated as to what is the dose per muscle, per site, per session, number of muscles and things like that, because there's a real risk of under-treatment and thereby you're not getting the desired response. What else about dosages? So there's a lot of factors about why sometimes when you give Botox, it doesn't respond. There are several factors to be considered. One, the severity of the cerebral palsy itself using the gross motor functional scale has to be evaluated because there is a varying response. Other medical problems, especially dysphagia, aspiration, pneumonia, and severe CP, because they will have more chances of getting severe serious side effects with Botox. Type of movement disorder, if it's predominantly spasticity as opposed to a dyskinetic, it's likely to respond better. The muscle itself in question where you're injecting matters, the bulk of the muscle, therefore the dose varies. And you have to clearly distinguish between spasticity and fixed deformities. Nutritional status and BMI for obvious reasons, because the dose is per kilogram. The injection technique, whether it's a blind, whether it's ultrasound guided, whether you use a nerve stimulator, whatever is this thing. Local anatomic factors, because injecting into the upper limb is different from injecting into the lower limb. So the dilution varies. What else do they say about safety and talk? Because there's a lot of concern about serious side effects. So it's been listed as these are 3 side effects. The local adverse effects are anaphylactic reaction, or you don't have the desired response, or you have an exaggerated response. That is specific to the botulinum toxin itself. Generalized adverse events are much more serious, wherein you have systemic adverse events. Procedural is directly related to injection, hematoma, infection, and things like that. So that's the way to look at it. The key is assessment in terms of, is the child appropriate for Botox therapy? And how you assess is you have to have some measure of quantifying your spasticity using various scoring systems, functional evaluation by the GMFCS, and gait, whether it is observational, video, or instrumented. So there are well-established guidelines in terms of consensus about, how to kind of this thing. And there are, if you search this, there are clearly defined charts as to how you can kind of work out whether Botox is appropriate. Now, coming to non-responsiveness, why do sometimes you don't get the response despite this thing? A lot of time it is a technique, whether the injection technique is accurate in terms of dosing, or whether the right muscle has been injected, or if your assessment has been faulty. If there is a predominantly contracture, this thing, you're not going to get a response. Spasticity reduction is not going to help you. Formation of antibodies is well known. And then you have sometimes a dose, temporarily the effect wears off. So you need repeat injections. So parents and family may not be willing to accept that. I admit it's not a completely, solved issues. There are clearly unresolved issues where still good evidence is lacking. Ideal time to start, off-label people are using it below 2 years, even this thing, but it's not established. What is the frequency of injection? How often do you repeat it? When do you stop? These are unresolved issues. Now, attempts have been made to kind of, try and fit it into the overall scheme of this thing. This is what is called a CP graph, wherein, the orange line is where the Botox is. And depending on various this thing, you can see as you go up in the severity of this thing, you have to be injecting it more and more earlier. You can see that, the D is where you expect more than 75% response, 75% of response. So, that is the thing. GMFCS1, you don't need it at all. And ideally, you inject it before you evaluate for surgery. So you get timed so that you can delay the surgical intervention. So there are established this thing. Now, what's the best evidence? I'll wind up with these 2 slides. Into the calf is where most of it, this thing. There is clear evidence that it helps the spastic equinus and improves gait. It definitely improves functionally, probably not as much, the evidence is not as robust as the gait improvement. Whereas into the adductors, there is some limited evidence to say that functional benefit purely for care. There's no improvement in the GMFCS. The functional improvement is not so much that the GMFCS improves. And in terms of protecting the hip, there is a temporal delay, but no influence on the long-term outcome. In terms of adjuvant therapies, what's the evidence available? Casting, there's no clear evidence. All of us cast, some of us cast it, some of us don't. When do you do it? Do you do it before? Do you do it after? There's no clear evidence that Botox in combination with casting is superior, except when there is an element of contracture. AFOs, clearly there is some evidence that gait improvement helps if used in conjunction with botulinum toxin. And clearly physiotherapy, whatever modality, be it strengthening, be it stretching or targeted training. Thank you.
Fishing in time now, I invite Dr. Alok, who is debating against the use of.
It seems quite difficult.
Yeah, thank you so much, Dr. Manoj Padman. Having spoken for Botox, it is very difficult to defend only surgery, but I'm speaking for surgery because this is what I do. Now, if I've just got 5 minutes to go through it, I do not think I require all this. I can just speak like that. Now, most of us are working in a medical college setting where the child is brought late. Now, once the child is brought late, the indicative age of Botox has already been missed. So when I see the patient in the clinic, and if I start applying Botox injections in them, and I expect them to return after every 3 months, I can assure that nobody will return back. Not only this, the family has other children to look after. There is not only one child, there might be 4 or 5 children. And coming for the care of a single child may lead to carelessness for the other children. Now, the scenario in, the in a developing country is like this, especially in a medical college setting, that when the patient is brought, whenever he is brought, even late, the physician who's treating may not be sure whether this child is not walking because of the initial brain insult or because he was never diagnosed before and a therapy was never started before. Now, if such a child, usually the child is brought in between 4 to 6 years of age. And usually the indication for Botox is usually a younger child. Now, whenever the family comes to us, they expect that something will be done and they will be able to take the child forever. And they will not be coming to the hospital again and again. Here comes the role of single event multi-level surgeries. Now, there are several Western papers who will be telling you that no, SEMLS, the single event surgeries are more expensive as compared to the Botox injections. But if you consider the Indian setting, where everything else is provided by the government hospital, the bed is provided by the government hospital, the treating physician does not require any kind of special training, Keeping these things into consideration, single event multi-level surgeries are much cheaper as compared to Botox injections. And it doesn't require much. It doesn't require any instrumented gait analysis. It just requires observation of the gait. It just requires static and dynamic muscle function testing, and that's it. And overall, a sound clinical judgment. Now, taking you through some examples, for example, hip. The most common deformity in the hip is flexion and adduction deformity. It has been tested that Botox and bracing, they have not been able to reduce the progressive hip subluxation. So why apply it? When you know that it is not going to help it, why apply it? Besides that, hip muscles are deep. They are large muscles. So they are not very good candidate for the Botox injections. And besides that, whenever you're doing single event surgeries, they also give you chance to do reconstructive surgeries like derotational surgeries. Botox has no role in that. Knee, at the most, it has got a temporizing effect upon the muscles of the knee. This is not a permanent therapy. So when you can do something simple, why go for something for which the patient has to come back to the hospital 4 times in a year? Now, ankle and foot, I think, is the most acknowledged area where Botox injection has been tested, tried and tested, and has given good results. For upper limb deformities, the Botox has been used only for testing the effect of the selected operative management. As Dr. Athani had told, that most of the times the children in between 4 to 6 years of age are treated with surgery and not with Botox injections. Spine, Botox has no role. It is bracing and surgical stabilization. I'll take you quickly through these clinical scenarios which we encounter in our clinical practice. An average orthopedic surgeon who's treating CP will encounter these examples. Now, this is a patient with a jump knee gait. His gross motor function is 3. He is walking with in-toed gait, and there is repeated fall. On examination, the hip is showing no flexion deformity, mildly positive Duncan-Ellis test. The knee is showing spastic hamstrings, popliteal angle 55 degrees, and ankle has got bilateral equinus with silver scale positive. Radiology is showing increased anteversion. Would you like to do Botox? I do not think it has got any role. Solution, we know the solution is not Botox. It is distal hamstring lengthening. With rectus transfer, most of us will do rectus transfer to semitendinosus and bilateral vulpes. And later on, when the child is old enough, we can add derotational osteotomy. Another common example, iatrogenic crouch gait, where bilateral tentaculus lengthening has been done wrongly for wrong reasons and has led to crouch gait. Now, on examination, the hip is flexion deformity 40 degrees, knee is showing bilateral spastic hamstrings with popliteal angle 55 degrees. Is the answer Botox? It's an 11-year-old child. No, it is not Botox. The answer is bilateral psoas lengthening, bilateral medial hamstring recession with or without supracondylar extension osteotomy. Similarly, a severe flexed gait in an 8-year-old child. Gross motor function 2. On examination, prone test is positive for the rectus, and the knee is showing popliteal angle of 60 degrees and a fixed flexion deformity of 10 degrees. Is the answer Botox? Again, no. So the kind of patients we receive in our OPDs, in our clinical practice, they are not the candidates for Botox. Having said that, I'm not I'm not trying to dislodge the position of Botox, which it has gained in the Western world, but it requires a lot of time to come for us to achieve that position over here in India. Now, where does Botox help? The role of Botox, according to me, as far as I understand, is just to delay surgery, to prevent a contracture, to delay surgery, and to facilitate physiotherapy and mobilization. It can also be used to investigate response of a surgical plan. But obviously we are not doing it, and once you are doing good examination, accompanied with examination under general anesthesia, you will not require this. And last but not the least, the Botox injection should not be taken as versus single event multi-level surgery. It is just complementary to the treatment. So the indications of both are quite different, but at last I would like to say that there is only one condition where it has been tested to be successful, and that is equinus, and equinus with various modes of mediolateral instability. Thank you.
Thank you, Dr. Alok. So, Dr. Alok, please stay here. Dr. Manoj, can you just join Dr. Alok? You want to arrive at a consensus, or you want the argument to continue even after?
I don't think there is an argument.
We arrive at a consensus, or the argument continues, and then we take the questions for the rest of the... Yes, sir.
Mike.
Mics, please.
I think this debate of botulinum toxin versus ACMLC is not a debatable issue, first of all, my first comment, because both are not comparable at all. And botulinum toxin has a specific role, that is it is a very good adjuvant in the overall management of cerebral palsy. It has a role, it has specific both in upper extremity as well as lower extremity, may not be in spine, as Dr. Sood mentioned. And it has no age limitations also, because being given to the very young, in first year also the Botox being given nowadays, and this can be given. But where is the problem as far as the botulinum toxin is, as in my long-standing experience I can say, the number one is that it is the very cost prohibitive. In Indian context, and because the cost is very prohibitive, surgeons try to compromise, even pediatricians and surgeons try to compromise on the dosage. That is, if the child requires 300 units, they say you will prescribe one, throw ek to leke aao kam se kam. That kind of compromise in our dosage is there. Third is that there is the selection of the specific site is not there. And even the literature, extensive review even if you do the extensive review of the literature, three things Dr. Padman will not be able to tell me clearly even as of now. What is the dose per muscles? How much should I inject to iliopsoas? How much should I inject to hamstrings? How much should I inject to gastrosoleus in a different age group? It is again 1 to 20 units, 25 to 30 units. And one thing that is known is 29 units per kg body weight is considered as the lethal unit as far as this is concerned. So one should not go up to the level of 30 units per kg body weight. But so there is no dosage, well-defined dosage. Giving prescription of injecting site becomes very difficult, and these are the reasons why botulinum toxin, though has a value, has remained by and large and has to be used in a more judiciously. It is mostly used in a very compromised fashion, rather though it has its own its usage. And fourth problem, last but not least, is botulinum toxin, because it is easy to administer. Every specialty is using it as a sort of pediatricians also use it in OPD clinic, orthopedicians also use it in OPD. It has become a sort of a easily admissible OPD procedure, and in a very compromised fashion. That is what is the real problem. But the literature review show that it is definitely has a good adjuvant in the overall management of this one, and one has to define, treating clinician has to define its role when it is to be administered and how much it is to be administered. This is what comment I would like to make.
Thank you, Dr. Thani. So do we arrive at a consensus?
I think it's been well summarized. That is an artificial debate. Dr. Thani and Dr. Sood concluded as well that it is not Botox versus surgery. It has a place in the larger this, and that's the key thing, And early surgery has its drawbacks, and that's also well known that you will end up doing repetitive surgery. So it is not either or, it is complementary, taking into all factors that, where you practice.
So to conclude, basically it is to delay the surgery, and in a limited number of areas of the body, it is basically useful.
Absolutely. All the cases which Dr. Sood put up, I would agree that Botox has no role, because they are older cohort of people, and they probably surgery is the prime role. So that is, you shouldn't mix up apples and oranges.
Thank you.
So any other, please stay here. Dr. Matthew
Questions,
and
yeah, for the previous talks by Dr. Matthews and Dr. Athani.
Dr. Matthew, Dr. Athani, any questions?
So please come to the podium.
Matthew,
Please come to the podium, sir.
Dr. Athani, sir,
Please come to the podium, sir.
So while patella tendon shortening is a well-known procedure in crouch, you also mentioned one interesting development, that is the tendo-Achilles plication. So I have not come across that in literature. So could you elaborate on that, and what has been your experience with that procedure?
Once the tender Achilles gets overstretched, getting it back to a normal function is very difficult. However, the procedure has been tried to at least get the ankle from a calcaneus position to a neutral position, and therein where we do, it's like instead of doing Z-plasty to lengthen it, you do that kind of a procedure where you have two tags coming from either side, and you double breast it, and you double breast it in such a way that the length of the tendon is shortened, that's all. There's nothing else to it.
And you do it if there is a plantar flexion lag.
Sorry?
You do it if there is a plantar flexion lag.
When there is a plantar flexion lag. And plantar flexion lag has to be tested out in a patient, where you ask the patient to do plantar flexion, and then check passively how much further it can go plantar flex. So that tells you.
But shall I make one comment on this?
Yeah.
Question. I have one question for you.
Shall I make one comment?
Many have contractures, so you can't do anything there. You have to do.
You said that you do a ligamentum patelli plication if there is a lag. But do you go with a physiotherapy strengthening of the quadriceps prior to attempting surgery, or all the cases it's a straight away surgery?
No. At no time do you go straight away for surgery. It is assumed that the child has undergone therapy and has been on treatment, because most of these children have been on therapy for a long time, but there has been a hesitation or access to surgery has not been there, and you have allowed them to go from toe walking position to a crouch position. So that is why it has happened, and therefore you assume that you have to have therapy for a certain period of time, tried out stretching and quadriceps strengthening exercises and failed, and therefore you go in for the surgical procedure.
Yeah, Dr. Varghese, you were telling about very nicely about the crouch gait. For Steven from United States, for last 15 years, and we have also learned, we are also doing, he puts in the where there is a flexion deformity, below the age of 12 years, 13 years, the EPPC is not fused. 2 plates on each side, the patella of the figure 8 plates on both the sides. So gradually the anterior portion is blocked. In the same way, in the valgus foot, plantar flex foot, there is a valgus deformity. They put 1 plate figure 8 on the medial side. He is having the experience of 15 years. We are having the experience of 5 years. What is your opinion about that?
Yeah.
Do you do that?
Yeah. I deliberately did not talk about the growth modulation technique for correcting the flexion deformities, because there are controversies regarding that now. So until that process is actually stabilized, I didn't want to push for it as a recommendation, because there are controversies regarding that.
Yeah, Dr. Steven was telling me, for last 30 years, we were doing the cerebral palsy, soft tissue surgery, bony surgery. Ultimately, I have changed my idea, and we are doing this technique. Thank you.
So there is a controversy on this growth modulation for flexion deformities. It doesn't work out as smoothly as you want it to work out.
So I think
So Dr. Khan, so you wanted to make a comment?
I just wanted to make only one comment, that is the advanced patellar tendon plication should be when the person is having crouch gait for a very long standing duration. Invariably most of them have the patellofemoral, early onset of patellofemoral arthritis and cartilage fibrillations, and reducing the length of patella might lead to sometimes the severity of the pain as well as reduction inferior pole of the patella problems. So that is no, this is the one of the problems which we encounter. So one has to be very clear. It, as like Dr. P.N. Gupta mentioned, there has to be sufficient trial for the time or the lag to be overcome by physiotherapy and other means. And second thing, there should not be coexisting quadriceps spasticity, and there should not be any kind of chondromalacia, early signs of chondromalacia existing underneath the patella. Then, if at all, one can think of doing the patellar tendon advancement.
Actually, many of these cases, if you check for the LP-LT ratio, LP will be significantly lengthened with a significant patellar alta. You check for patellar alta and you will invariably get it. And while you're doing clinical examination, of course, you do test for the undersurface tenderness. That will tell you whether this patient is going to have a problem on plication of the ligamentum patellae.
So one last question from
with the permission of the chair, a small comment about Botox. Perhaps in a lighter vein, it seems as though a lot of pediatric orthopedic surgeons make it a point to tell the patients and the parents that every other modality of treatment is outdated, old, ancient, to be given up, is of no use. For example, casting, surgeries, and that Botox is the modern way of going about doing things. And that's a way for them to kind of, get into the higher brackets.
So thank you everyone, and we really enjoyed. Before I close, just want to echo the words of the famous surgeon Dr. Salter. What he said, that if you operate on a child of CP, he still has CP. Now this might seem very discouraging, but even small interventions make a big difference in the lives of these children. So I hope we'll go wiser from this symposium. And the one more thing, that in a child with cerebral palsy, making decisions is much more important than giving incisions. Okay? So with these words, I close this symposium and thank the organizers for inviting us.
Well, thank you, Dr. Vikas and Dr. P.N. Gupta, for that very comprehensive session. We come to the next session, and I would request Professor Alok Sood and Dr. Matthew Verghese to please chair this session. This is a session on clubfoot.
Thank you, Dr. Shah Alam. And on behalf of Dr. Alok also, I welcome you to this session on clubfoot. We start with the first speaker, current concepts in the management of clubfoot, Dr. Shah Alam Khan.
Well, thank you, Dr. Matthews. So I'll very quickly take you through what is happening in what is happening on the recent front in the management of clubfoot. Now, if you see this phone, this is a Nokia phone which is foldable. So you could actually fold this phone and keep it as a band on your wrist. Now, compare this to what this gentleman, Graham Bell, did many, many years ago when he first said, Mr. Watson, come inside, I want to see you. And what he wanted to show was the picture of a telephone that he had made. So things have really, really changed, and they have changed pretty dramatically. As far as the current issues in clubfoot go, I would like to talk about what is current in etiology, pathoanatomy, diagnosis, classification, and treatment. And it is ironic that in the clubfoot section of current concepts, that the picture of a 95-year-old man appears. So that's what is current really. So coming first to the etiology, this was a very good paper on update on clubfoot etiology and treatment. The most important things were that there is increasing evidence that clubfoot severity and treatment outcomes vary by etiology. Of all the known etiologies that we know about clubfoot, those involving nervous system comprise the greatest numbers. There are definitely risk factors now we know, like for example smoking, amniotic fluid leak, early gestation amniocentesis, which can cause clubfoot. It was on the 1st of October 2008 that this gene was released by the Washington University of Medicine, and this is the only gene, the PITX1, the gene which is the first gene thought to be involved with clubfoot. So that's as recent as about 4 years ago. Now we know that coming to the pathoanatomy, what's new in pathoanatomy? Pathoanatomy, foot has changed over time. The foot, this is the foot of a prehistoric man, and then subsequently became a very organized organ of locomotion. But we recently came to know, not recently, about 40 years back, but more in the recent, appreciated more in the recent time, that the foot moves with the calcaneum, and the concept of calcaneopedis block was developed. So what happens is, now if you see this over here, this round thing is actually forms what is called as the acetabulum pedis. This is the acetabulum of the foot into which the head of the talus moves, and this is pretty a new concept. And then trochus ligament is the center of rotation for the subtalar joint movement. And the movement was first described by this gentleman, Farboff, and he gave what is called as a concept of kinematic coupling, that the foot moves like a boat. When it rolls, it yaws and it pitches, and these movements were taken from here by Ponseti to give us the pathoanatomy of foot in terms of what is called as kinematic coupling. So this is talus, the calcaneum, that subtalar joint, and there you see the star is actually the trochus ligament, on the axis of which the whole of the foot moves. So when you move the talus, you are actually moving the whole of the foot across, and this is what is called as the kinematic coupling. Now coming to what is new in classification, we do know that Shafiq Pirani gave his classification of congenital clubfoot, and this is called as the Pirani's classification. We all are very used to this. I'll just quickly take you through. So he's got a midfoot contracture score, which consists of curved lateral border, medial crease, lateral head of talus, a hindfoot contracture score consisting of the posterior crease, the rigid equinus, and the empty heel. So all this has shown that with the Ponseti's method, the Pirani score tends to go down and up to a point where you have to do a percutaneous sternotomy, and then the total score also goes down and the foot achieves a normal anatomy. So this was a concept which is very new and which was kind of revolutionizing. But a new classification of clubfoot was also given in the 90s, and this was by DiMaglio, Alan DiMaglio. This is a more comprehensive classification, not very easy to use in a clinical setting. Now, what is new in diagnosis? We all know we can diagnose clubfoot. Well, this thing, the atypical clubfoot, came into existence around 1999 and 2000. It is considered to be a consequence of Ponseti's treatment. The foot has got very severe equinus. It is short, hyperextended, and the great toe is cocked up with a chubby dorsum of the foot. And this was actually explained by Ponseti as a complex idiopathic clubfoot. Whether it was complex or not, whether it was a result of his own treatment was not known. So it is difficult to usually treat. Now, you see in the picture, there is a medial crease running across the foot, and I just came to understand from Dr. Matthew Verghese last week actually, that as current as that there's a dorsiflexion test, a plantarflexion test. If you plantarflex the foot, the crease tends to run throughout, and that's a good test to see in a atypical clubfoot. So it's difficult to treat. You have to give what are called as plaster holidays. They do not respond to regular Ponseti's manipulation, and the main pathoanatomy in this is a severe amount of plantar flexion of all the metatarsals. So there is a plantaris deformation areas, and then try to correct the foot. Of course, there are papers which compare the two methods, the Ponseti's method and the French taping method, and they both conclude, all the papers conclude, that the results are in both the groups are similar, but more and more parents and more physicians want to opt for the Ponseti's treatment when given the choice. So therefore, this man becomes very important in the current lecture. He was, of course, you all know, a product of this Spanish Civil War. His method was described more than 50 years back, but gained popularity in the 90s. It is established treatment now in almost all types of club feet, first given in 1954, low acceptance at that time, and as I said, gained popularity subsequently. The treatment starts at birth, which means in the first month after birth. First, you reduce the cavus, as you see in this picture, which occurs due to pronation of the forefoot and the hindfoot. You reverse the maneuver and correct the alignment, and usually it's supple and only requires supination for correction. That is the basis of correcting the cavus. So first, correcting the cavus, that is the most important thing you need to do by lifting the metatarsal up. First metatarsal. Next important step in the Ponseti's manipulation is to palpate the head of talus. It lies in front of the lateral malleus, not below it, as Kite had described for the calcaneocuboid joint. It has to be very precise, as precise as possible, although it's difficult in small and stubby feet. That's a very kind of an ambassador slide of Ponseti, which shows each cast showing improvement in the deformity, and that's pretty dramatic. So that's just a quick picture of how the manipulation is done using one hand or two hand techniques. Now, when do you do a tenotomy in Ponseti? There was a bit of debate initially. It is done when the anterior callus can be abducted from underneath the talus, and an abduction of 60 to 70 degrees is possible. So basically, if you see the Pirani score, you have to do it when the lateral head of talus has totally become 0 and the score is less than 1. So it is done 1.5 centimeters above the calcaneus. So there you see the foot, when the foot is being held in maximal dorsiflexion, and give a post-tenotomy, give a plaster for about 3 weeks. Why don't we do a posterior ankle release? Because whatever you gain in posterior ankle release is lost in the next few years. So it's really no fun doing that. So I do it in children who are pretty big. So this is a child who's 10 years old, bilateral club feet, that's his picture. You see he still has residual deformity, but pretty good as compared to what he was. A unilateral right-sided club foot, age 9 years, and there you see a good correction. And we, of course, publish our results in the Journal of Pediatric Orthopedics in children more than 7 years of age. The average age was 8.9 years, success rate of around 85%. And we concluded that Ponseti's method should be the first line of management, even in neglected clubfoot. Very, very relevant for India. And that's another child, age 8.5 years, good correction. And yet another one, age 8 years and good correction, unilateral. Now, what is the evidence of Ponseti? Although we have a debate on this, 30-year follow-up of patients who had PMSTR for clubfoot were compared to 30 years of Ponseti's result, and we saw that the Ponseti's group had a large number of good and excellent results. And very importantly, very, very relevant in India, Ponseti in the lower resource settings, successful programs of clubfoot care in many low countries have been running. We all know that globally there is a lot of inequality. And the rate of correction in poor countries like Chile is 99%, Egypt 96%. India, I'm not sure if that's a poor country. 92% and Malawi 98%. And also Ponseti can be applied by a non-orthopedic surgeon, by a non-orthopedic practitioner. So clinical officers in Malawi used it with a 98% success rate. Even in UK, this is Rebecca's paper, 97.5% correction rate when it was done by physiotherapists. And of course you maintain it with what is called the foot abduction brace. This is again a bit of recent thing developed by Steenbeck. It prevents recurrence and is an essential component of Ponseti's treatment. The effectiveness of brace is the single most important factor which will prevent a recurrence in children who have had a correction by Ponseti's method. Of course, we do regular checks whenever they are in, for example, this child, you just see these small little tiny little callosities in the anterior part of the ankle, which means the child is wearing the brace correctly and as prescribed. Is there no role of surgical management? No. We have a whole array of surgical procedures, soft tissue releases, bony procedures, tendon transfers. Of course, it's important to know the timing of procedure and which technique. So are they gone? Is this the end of surgery? Not really. My teacher, Professor Jaiswal, gave me this case. This was 23-year-old with a 22-year follow-up of surgery, and he had pretty good results. So surgery is not out. And of course, we have papers which demonstrate that surgery is still an option. So what is the take-home message? Clubfoot has got a multifactorial etiology where genetics plays a very important role. We now know that gene even. You understand the kinematics of the foot now better than what we did a few years back. Ponseti's method is the ideal method for most type of clubfoot. I would in fact go and say no Ponseti, no clubfoot, no Ponseti, no clubfoot. And in the end, surgical intervention has a very specific but very limited indication. So this man taught us something many years back. And what I would say is you blend the East and the West and you get the best. Thank you so much.
Thank you, Dr. Shalom. I think we'll have questions in the end. Good overview. Can I now invite Dr. Manoj Padman for his talk on surgical management of the clubfoot.
Dr. Shalom has set the tone very well at RIP for surgery. So he's given me the difficult task of following his excellent talk. And just to clarify, because, see, I'm not advocating surgery. I am talking about the role of surgery in clubfoot as a general thing. Just so that you don't get any this thing that I hold no brief for Botox as well, just to present the evidence of role of Botox in this thing. That's the same thing, I would concur with everything that Dr. Shalom has said, and I'd say there's very little role for surgical management of clubfoot, end of talk. Yeah, but we have to go through the process. Yeah. So as I go through role of surgery, this thing, what I want to start off is, what is the evidence? So in 2004, Ponseti's own group came out with this thing that there's a radical reduction in the rate of extensive corrective surgery. You would expect that. He's devised the method for non-operative treatment, so he's going to actually say surgery is not working. Yeah. Subsequently, looking at multi-centers, several surgeons involved, and has the rate of extensive surgery reduced. And you can see that over a decade, from 1996 to 2006, this is only in children under the age of 1 year. So we're not talking about relapse, we're not talking about, the older child. We're just talking about primary this thing. That's the drop. Okay? And that's a graphical illustration. It's not as if clubfoot has come down. Clubfoot incidence and prevalence remains the same, but the one in pink, which shows the surgery, how much it has dropped. This is across several surgeons. The same thing, you can see that In 1996, it was about 70% surgery. In a decade, it's about 10%. That's the role of surgery. So you might say that that's all from the West. What about in underdeveloped publications from Nigeria, which clearly say that, what are their figures? So if you look at that, this is the Ponseti group, and that's a non-Ponseti which had this thing, and you can see no surgery in about 95% of the Ponseti group, whereas only about two out of three ended up having either intermediate surgery or major surgery. So if you're just talking about just the immediate what about long-term outcome? Looking at a group of normal individuals, some who had a single surgeon series of clubfoot soft tissue releases, extensive releases, the circumferential releases, and clubfoot. Yes, the club feet were not normal compared to were slightly deficient in function compared to the normal feet, but much better than the surgical So again, there's very less role for surgery. So why am I talking here? Is there a role for surgery? If so, what and when? Most people would agree that there is some role for surgery, like an a la carte. It's not like, everyone gets, if plaster fails, everyone goes for a posteromedial soft tissue release, which is what used to be 15, 20 years ago. So in terms of anatomy, what are the surgeries that can be done? These are the structures where you can operate upon. Tendons, Achilles tenotomy, open lengthening, less frequent. The results, long-term results are not as good. Percutaneous Achilles tenotomy as part of that surgery as well. It's part of Ponseti treatment. Soft tissue releases, limited soft tissue releases. If you have, these are a la carte. If you have a cavus foot, you do a plantar fascia release. If you have adductors, which is not responding, abductor hallucis release, limited capsulotomies, but very little role for extensive releases, and that's why the small print. Yes, in syndromic clubfoot, you may have a role, but primary idiopathic, very less. Tendon transfer, this is a very useful, in Ponseti's own series, almost 1 in 3 had a tibialis anterior tendon transfer. Bony surgeries, lesser and lesser for primary clubfoot, and joints, even lesser. So just to kind of run through these, the Achilles tenotomy, you could say that it's part of the Ponseti regimen, so we'll not take that as surgery. Open lengthening, if anything, it's a very limited and it's in an older child. You may have to even excise a segment of the tendon in arthrogrypotic if you have had not good results with repeated tenotomies. I'll spend a little bit of time on tendon transfer because that's the next, in terms of the numbers, after Achilles tenotomy, that's the commonest surgery that I do in clubfoot, tendon transfer. And this is a whole tendon transfer to the lateral cuneiform as described by Ponseti. Purely for dynamic supination deformity in an older child where the lateral cuneiform has ossified. You can see it. The original description was a 3-incision technique, but there are modifications of a 2-incision, and I use the entire tendon. Just to go through a few pictures, that's the medial side incision. The entire tendon has been detached. A whip stitch is put through it. So you have a proximal incision. You isolate the tendon again there. You pull it out, and then you make the third incision over the lateral cuneiform. You put a small needle to confirm your landmark because you need to drill a hole, you need to anchor it in the bone. Take a C-arm picture, a single shot to confirm your landmark. You can see the tendon rerouted back, attached both at the dorsal side as well as plantar, either over a button or a roll of gauze. So this is purely for dynamic supination deformity, and in the original series, probably about 30% of children who need it. What about soft tissue releases? Sometimes in conjunction with this, limited soft tissue release for plantar fascia, release for cavus, and adductors appropriately. But very little role for the traditional extensive soft tissue releases. Bony osteotomies, very little role, only in older children as part of salvage reconstruction options. If you're doing an Elizarov reconstruction, and if it is an older child who's been multiply operated and who is, the foot is quite stiff, you may have to do calcaneal osteotomy and midfoot osteotomy. Again, these are all historical now. You have, so this is again part of, just for completion's sake, soft tissue distraction using Jess or with Elizarov. If you use soft tissue and bony, then you will have to use an Elizarov. Concurrent osteotomies are required. You may have to do stage procedures, hindfoot first, followed by midfoot 3 weeks later. And that's an Elizarov frame in a 12-year-old who had multiply operated clubfoot. Salvage options. Triple arthrodesis is a salvage option, is a purely salvage option in a painful, stiff foot. Talectomy is a good operation in an arthrogrypotic who's not had any treatment. So to conclude, if the pendulum has swung towards the non-operative side. Clearly, that's where it should be. That's the take-home message. The role of surgery is very limited in selective cases, but it has its role. But clearly, overwhelmingly, the balance is shifted towards non-operative treatment. And that's again well validated by a survey which was conducted amongst pediatric orthopedic surgeons that the extensive surgery has this thing. So wherever you look at it, that's the way the practice has changed in the last decade or so. Thank you.
Thank you, Dr. Manoj. I now invite Dr. Vikas Gupta. Debate surgical versus pauncity in the older child more than 5 years of age for pauncity. For pauncity. He is speaking for the motion.
So thank you, sir. In regards to chairman, I think my job has been made easier by Dr. Alam and Dr. Manoj, but still. Now we see there is abundance of late presenting cases in our country. So we question ourselves, is there a role of pauncity in these older children, walking children with clubfoot? And to study the factors and which would affect our result other than the age. So we all know that clubfoot deformity in the older child, if it remains untreated, leads to the downward spiral of disability, dependency, demoralization, and carries a significant social stigma, especially in our country. Moreover, abnormal pressure distribution over the ankle and foot in a walking child results in a complex foot deformity with recurrent skin breakdown as well as infection and need for special shoes. With time, there are compensatory changes in other joints such as spine and as well as the knee also. Now, the pathological anatomy is very complex in these late presenting cases. Soft tissue contracture on the medial side is further made to contract as the child walks, and the bones which normally are supposed to make the arch of the foot now bear axial weight, which they were never intended to do so. The subtalar joint goes into maximal position of supination, and there is a marked obliquity of the calcaneocuboid joint. Now, the mainstay of these late presenting cases was mainly surgical, I would say, in the past. And the surgery is very complex, difficult, as well as labor intensive, and is accompanied by high failure rates such as overcorrection due to indiscriminate release of the ligaments,